Hello, welcome to this talk on variceal upper GI bleeding. My name is Dr. Anthony Leahy. I'm a consultant gastroenterologist at West Hertfordshire Teaching Hospitals, and I'm doing this talk on behalf of a training company called Endotrainer. The objectives of this talk is to address the pre-endoscopy management for the patient, and then during the endoscopy, lesion recognition for portal hypertension and the various endotherapy options available for the endoscopist, and then following the endoscopy, any ongoing bleeding and rebleeding strategies. This talk is basically based on a couple of sets of guidelines, the first of which was published by the British Society of Gastroenterology in 2015, and then more recently the European Society of Gastrointestinal Endoscopy in 2022 regarding the comprehensive diagnosis and management of esophagogastric variceal hemorrhage. Before we talk about variceal hemorrhage, just a couple of slides to talk about primary prophylaxis to try and prevent your patients having variceal bleeds. Basically, it depends on the size of the varices, grade 1 varices being just visible, and grades 2 and 3 larger, and I tend to remember that grade 1 esophageal varices tend to disappear when you inflate the esophagus. In 2015, the BSG recommended that all patients with a new diagnosis of cirrhosis should be considered for a screening endoscopy. If there were no varices seen at that index endoscopy, then it could be considered to re-endoscope the patient in 2 to 3 years. If there were small, just visible grade 1 varices, then it could be considered to repeat it at a slightly earlier interval at a year. But if there were grade 2 or 3 varices or any varices with red signs, then these are the patients that should be started on a cardioselective beta blocker unless they are intolerant or have contraindications to beta blockade. In those patients, and in only those patients, variceal band ligation was recommended. Since 2015, there have been new technologies allowing us to assess patients' liver disease in more detail, such as fibroscans. And if the criteria of having a liver stiffness less than 20 kilopascals or a platelet count greater than 150, this actually had a negative predictive value of 99% for ruling out high-risk varices. Therefore, ESCI suggested that in compensated liver disease, these criteria could be used to avoid screening gastroscopy. ESCI went on to address who to treat, and they suggested that carvedilol should be the treatment of choice for primary prophylaxis for high-risk varices. High-risk varices are defined as small varices with red signs or medium to large varices. Variceal banding should be used as primary prophylaxis for high-risk varices only if patients are intolerant to beta blockers. And when used, the variceal banding session should be repeated at 2 to 4 weekly intervals until obliteration. Moving on from primary prophylaxis, the BSG published an algorithm helping in the management of an acute variceal bleeding patient. Resuscitation should involve high flow oxygen and adequate venous access. Intubation should be considered. Transfusion is according to the hemodynamic state of the patient. In massive bleeding, then a massive bleeding local protocol should be followed. If the patient is hemodynamically stable, then normally a restrictive blood transfusion is followed, maintaining a hemoglobin above 70 grams per litre. The platelet count should be maintained above 50, and an INR greater than 1.5 corrected appropriately. The BSG suggested that a gastroscopy should be performed as soon as possible, but certainly within 24 hours, and more recently ESCI has suggested within 12 hours. This is the algorithm from the guideline from the BSG. With variceal bleeding of the esophagus, band ligation is the first treatment. If the bleeding is controlled, then after day 5, patients are usually treated with secondary prophylaxis with a non-selective beta blocker and usually a further session of banding. If the patient re-bleeds following that, then a covered TIPS should be considered if there is a patent portal vein. In more severe liver disease patients, such as child B with active bleeding or child C, then a covered TIPS should be considered at an earlier interval. If following band ligation variceal bleeding is not controlled, then a balloon tamponade was advised, but this was before removable stents came to the market. If we talk about band ligation, really speaking, you should start at the gastroesophageal junction and then band the varices, which has particularly signs of a recent bleed, or the largest first. I tend to band all the columns that I see in a spiral technique, and I tend to suck the varix with some tip movement and wait for a readout and then deploy the band. I also like to continue suction for a few seconds after deploying the band and then release suction, making sure that the band will not slip off the varix. If you can't control the variceal bleeding, then a Senstack & Blakemore tube is often considered. I always test the two balloons, the gastric and esophageal balloon, to make sure that they inflate correctly, and I always make sure that I have all the equipment to hand that I need prior to the tube insertion. I like to insert the tube through the mouth, usually endoscopically guided, but sometimes other endoscopists will insert it over a guide wire. The tube is inserted deep into the stomach, and then the gastric balloon is well within the stomach. I usually inject 250 ml of air into the gastric balloon and then pull the whole tube back until I feel traction with the inflated gastric balloon at the gastroesophageal junction. I avoid inflating the esophageal balloon and will only do that if there is continued bleeding, and will only inflate the balloon for a very short period of time. I tend to apply traction to the tube outside of the patient. Some people use tape, others a small weight, and the Senstack tube should always really be removed after a 24-hour period. Senstack tubes do have some significant adverse events, including esophageal ulceration, perforation, and aspiration pneumonia. More recent to the BSG guideline, removable stents were marketed for use in esophageal varices, and in particular, the Danis stent is the most widely used. ESCI looked at these removable stents and suggested that there was some evidence from a single randomized study suggesting that stents could be superior to Senstack tube insertion for bleeding control and adverse events, but no difference in survival. Moving on to the management of gastric variceal bleeding, different centers will either use glue or thrombin injection. If there's a failure to control gastric variceal bleeding following injection, then it's recommended to use balloon tamponade, as removable stents will not work in gastric varices, and also then to consider a covered TIPS if the portal vein is patent. There's no clear consensus for secondary prophylaxis from the ESCI guideline, and the BSG earlier to that suggested secondary prophylaxis such as further glue injection or a non-selective beta blocker or thrombin. If there's rebleeding following any form of treatment, then a TIPS should be considered. Gastric varices are classified according to the diagram shown. GOV1 or GOV2 varices are at the gastroesophageal junction, either on the lesser or greater curve. Isolated gastric varices are separate to the gastroesophageal junction, as shown in the bottom two diagrams. All of these gastric varices can be injected, and sometimes GOV1 varices can actually also be banded. This slide goes through how to actually inject gastric varices. Thrombin is used because it's basically an easier to use for varices. I usually mix up 2,500 international units of thrombin with 10 mils of saline, and then you can inject 2 or 3 mils of that thrombin solution at a time. With glue, there's obviously a concern that the glue will solidify in your needle or in your accessory channel, or even worse, on top of the varix. Therefore, most endoscopists will prime the endoscopy channel and also the needle with Lipiodol and ask their assistant to mix the glue and Lipiodol in a 1-to-1 ratio. Before puncturing the varix, I prime the injection needle with a ml of glue mixture followed by a 1.5 ml of Lipiodol chaser into the needle. This means then that the 1 ml glue mixture will be at the distal end of the injection needle. I then puncture the varix and inject a ml of the Lipiodol chaser and withdraw towards the end of the injection, trying to prevent the needle sticking on the varix, which has never happened to me, thankfully. If bleeding can't be controlled with banding or injections, then a trans-intrahepatic portosystemic shunt should be considered. This is a technique where a catheter-guided needle is passed from the internal jugular vein to the right hepatic vein to puncture the portal vein. Then there is a guide wire inserted into the portal vein. The tract is dilated between the hepatic and portal vein within the hepatic parenchyma, and a stent placed in this newly formed tract. There are some contraindications to TIPS. If patients have severe or uncontrolled hepatic encephalopathy or extensive liver malignancy, progressive liver failure, or unrelieved biliary obstruction, then TIPS is usually contraindicated. Usually also large polycystic liver disease is in the textbooks listed as a contraindication, although there are some successful case reports of using a TIPS in these patients. Other contraindications consist of significant pulmonary hypertension, significant heart failure, and also uncontrolled infection or sepsis. ESCI in their paper nicely summarized the 3 main indications for TIPS insertion. They termed a rescue TIPS in patients with continued variceal bleeding despite pharmacological and endotherapy. Also, they termed salvage TIPS in patients with recurrent bleeding within the first 5 days after initial successful endotherapy. Also, you can consider a preemptive TIPS in patients with high risk of recurrent esophageal bleeding after successful endotherapy, and these are basically Child-Pugh C patients or patients Child-Pugh B with active bleeding at the index gastroscopy. One final slide talking about report writing. Each endoscopy report with regards to a portal hypertensive bleed should have the number and the size of the varices documented, and certainly any presence of any red signs and the presence of gastric varices. You should list the treatments applied and whether they've been successful or not, and then also quite clear post-procedure recommendations such as a splanchnic vasoconstrictor, an antibiotic, and the duration of whether you want your patient to remain nil by mouth. You should also help your team managing the patient with a rebleed plan and suggest that if the patient does rebleed, then they should be considered perhaps for a second endoscopy or a TIPS insertion. That's the end of this presentation, and I hope it's given you some useful information and summarizations of the two guidelines regarding the assessment and management of portal hypertensive bleeding. Thank you for listening, and on behalf of Endotrainer, goodbye.